speaker is another speaker that you probably, most of us know. Dr. Gary Curhan is a maven in stone pathophysiology. He trained here at Harvard Med, followed by a residency and fellowship at Mass General, and then a doctorate at the Harvard School of Public Health. He's now a professor at the medical school and the School of Public Health, and a senior lecturer at HMS. He has a striking expertise in stones and a clinical focus in stones, as well as a research focus in stones, chronic kidney disease, gout, hearing loss, tinnitus, and shingles. Gary, thank you very much for speaking with us. I look forward to your lecture.
Thank you, Alice. Nice to see you. Hello, everybody. I'm very happy to be here in the summer talking to you about kidney stones. The title that I was assigned was Metabolic Management of Kidney Stones, but the title that I want you to remember is this one, that kidney stones can be prevented. I can't tell you how many times I've seen patients that have had 2, 5, 10, 20 stones, and nobody ever told them this. The urologists are doing the best they can, but they're focused on stone removal. Our job as internists and as nephrologists is to think about the patient and what we can do to prevent new stones. And hopefully in the next half hour, which is a little bit short to talk about all stones, but we're going to talk over some cases that will hit on the high points. So I'm going to use case presentation. We're going to talk about the evaluation of patients with different types of stones, and then we'll review the approaches to prevent stone recurrence. So these are all patients that I've seen in my clinic. First one is Mr. MT, 52-year-old male, recurrent nephrolithiasis. He describes as passing small pieces continuously of this orange-colored substance. His past medical history is notable for ulcerative colitis. He's had a colectomy, and his meds, you can see, are listed there. So before he came to me, he had some evaluation. His serum bicarbonate was normal. His creatinine was a little bit higher than we would have liked. His calcium was in the reference range. Serum uric acid was not measured, and he hadn't had any recent imaging. So renal consult was requested, and things that I always think about the first time I get a patient referred to me is, what's the stone type? What's the evaluation that needs to be done? And ultimately, how can we help this patient to prevent new stones from forming? So given the information that you have, we're not going to have audience responses because of the limited time, but I just want you to think about this. What's the most likely stone type? It's going to be calcium oxalate, calcium phosphate, uric acid, or cysteine. And there are some clues in the history that I've given you so far. And if I showed you the urine sediment, which I hope you at least still get to look at every once in a while, all these crystals are from the same specimen. You can see they're very pleomorphic. They are a little bit yellow, orangish, and the correct answer is uric acid. And there's some key pieces of his history that should have caught your attention. First, the rapid stone formation. People with calcium oxalating, sometimes calcium phosphate stones, rarely will pass stones that frequently. They usually aren't orange colored, but you can't go by the color at all because blood and other things, mucus, can change the color. And then the key thing is, okay, what are his risk factors for uric acid stones? And the main risk factor for uric acid stone is persistently acidic urine. It's not how much uric acid is in the urine, persistently acid urine. And you can think of his chronic GI losses as resulting in a systemic metabolic acidosis, though his serum bicarb was still normal, okay? Okay, he was very proud. He sent me this picture of one of the very large stones that he passed. Okay, but like this patient, we were able to know the stone type, but oftentimes you're going to see a patient that's going to come to you for the first time, and you may not know the stone type. And if you have to guess, you should always guess calcium oxalate. Almost 3/4 of first-time stone formers form calcium oxalate stones. The next most common is calcium phosphate. And again, when people say they have a calcium stone, you want to know what the calcium salt is because the oxalate and phosphate act differently. The third most common type is uric acid. And then these other ones for first-time stone formers are smaller pieces of the pie. If we looked at recurrent stone formers, calcium oxalate would still be the most common, but the proportion of the pie would be smaller. Calcium phosphate, uric acid, struvite, and cysteine would get bigger because they're more likely to recur. But there's even more information that you can learn from the likelihood of different crystal type. if you break it up into men and women and then by age, this is from John Lissie's group at the Mayo, and you can see with increasing age in men, calcium oxalate far and away the most common. But you can look right here, this is uric acid increasing substantially with age. If you look at women, again, calcium oxalate most common most of the time. In the 20s, calcium phosphate and calcium oxalate are about the same. And once again, in the older individuals, uric acid's going up. But ideally, you're either going to catch a stone or ask the patient to retrieve it and bring it in, or looking at their urine sediment. I can't tell you how many times there have been crystalluria noted in the record for the lab results for years, and nobody's bothered to look at it. So as far as the main types of stones and causes, just very simplistically, low urine volume is key for all stone types. We'll talk more about that in a minute. But for calcium oxalate, high calcium, high oxalate, and low citrate, citrates are a natural inhibitor of both calcium oxalate and calcium phosphate stones. For calcium phosphate, alkaline urine. So unlike calcium oxalate, which is pH insensitive, calcium phosphate stones only form when the urine's more alkaline, and we'll talk about that in a little bit. But also high calcium, low citrate as well, also high phosphate. Uric acid we just talked about, persistently acid urine, though very high urine uric acid also can be a contributor. And then cystine is an autosomal recessive disorder. There's nothing somebody can eat or drink to make that happen. And struvite, these only form in the upper tract when there's a urease-producing bacteria. Okay, so let's go back to our first case, Mr. MT, and now let's look at his urine. Okay, I always ask people to do two 24-hour urine collections at baseline, and that's because there's substantial day-to-day variability in what people eat, and so their urine's going to be different. But the first thing you always want to look at is the creatinine, okay? And right here you see the creatinine is way more different than we would expect. So either one of these is an under-collection or one's an over-collection, or the diet was just so different on one day that he consumed a huge amount of creatine, which could be converted to creatinine. But there's really no way to know. So if we only did one collection, we'd say, oh, the urine volume's not bad at close to 2.5 liters. Urine calcium's higher than we'd like, oxalate higher, citrate lower, the sodium very high. You got to multiply this by 23. This is like close to 7 grams. And then if you look at a second collection, say, wow, the urine volume's much lower, calcium's not bad, oxalate's not bad, citrate's still low, the uric acid is lower, and the sodium's still high. So again, if we just looked at one of these, we could be very misled. But in both of these, again, remember the urine pH is so critical. In uric acid stones, when we say acidic urine, we mean a urine pH of 5.5 or less. So question about next steps. Well, the first thing I always want to do is get a good imaging study. And in this case, I would do a non-contrast spiral CT. And that's because I don't know if he's passing stones that had formed a long time ago, or is he actively forming new stones? So I want to get some sense of his stone burden. Ultrasound can give you some idea of the overall stone burden, but it can't discriminate very small stones or stones that are close together, particularly if there's a lot of them in the kidney. I definitely want to repeat his 24-hour urine because I just showed you the variability of those two. I didn't know which is his typical, and so not surprisingly, when he did a third one, it was like in between those two others. As far as prevention, we want to alkalize his urine. The urine pH, as I said, is the most important risk factor for uric acid stones, and so I would use either potassium citrate or bicarbonate, again, anything that's going to alkalize the urine. Most patients are going to require somewhere between 40 and 80 milliequivalents per day. And I do ask the patients to check their urine pH at home. They can easily buy urine pH tape, but make sure you remind them to not get the SPA pH range, the one that's physiologic. They have one that's 5.5 to 8. And make sure you also tell the patients to dip the paper in the stream, not in the toilet. But at home, then they can target their urine pH, they can send you the responses, and then you can adjust the dose of the alkali as needed. And you can actually completely stop new stone formation in uric acid stone formers. You haven't heard me say allopurinol. Again, if someone's uric acid is extremely high, I will use allopurinol also. But the main determinant, as you can see in this graph here, is the urine pH. So people that have even low total urine uric acid, if the urine pH is low, they go above the crystallization threshold. Okay, uric acid, favorite kind of stone. If we can alkalize the urine, we're good. Okay, the next patient, Miss GK, 45-year-old, recurrent nephrolithiasis. And when we say recurrent, that has all sorts of different meanings. We'll talk about that in a little bit. But she was passing stone every 8 to 10 months, so that's still, catches your attention, a little more frequent than you'd expect. She's had multiple procedures, extracorporeal shockwave lithotripsy 5 times, cystoscopy and ureteroscopy 6 times. PCNL, that's this percutaneous nephrolithotomy, where they had to put a nephrostomy tube in her back because the stone burden was so large. But otherwise, she was healthy and quite a good golfer. So before she came to me, she had a single 24-hour urine. Volume wasn't bad. Calcium, oxalate, citrate all looked really good. Her sodium was still a little bit higher. Urine pH was 7.3. I didn't tell you that she's actually on supplemental potassium citrate. So if you're thinking now, okay, what's the most likely type of stone in this person? Again, you should always guess calcium oxalate, but the 24-hour urine's like, that doesn't really look like someone who should be continually forming stones, assuming she's an active stone former. Calcium phosphate, I told you that her urine's alkaline, so it's possible that it could be calcium phosphate. Uric acid is completely excluded based on the very high urine pH, and cystine's certainly possible. So if you had to guess, probably the best bets would be calcium phosphate and cystine. And then if you looked at the urine sediment, which I hope that you would, and it may look like a bunch of schmutz until you start to see some of these things and these things and these things. And if we magnify that, then you see these beautiful hexagonal crystals, and you have just made the diagnosis of cystinuria. Okay, you don't need to do any other testing. You know that this person has excessive excretion of cystine. Again, it's an autosomal recessive disorder, and the excessive excretion of cystine is the issue because it's poorly soluble. So what can we do to prevent new stones in this woman who's passing frequent stones, have multiple procedures? So alkalizing the urine does help a little bit. Cystine is more soluble at pH above 7, and so she, again, will occasionally check her urine pH at home. She's been on penicillamine before, which is used to treat cystinuria, but developed a rash. So I also received a CT report that was done at a time of an acute setting, so that you can see here that she had a 4-millimeter stone at the left ureteral vesicle junction, a very common place for stones. All types of stones get stuck. It's where the ureter goes into the bladder at an angle. Very commonly will get stuck there. And in a woman, particularly a younger woman, the initial diagnosis may often be a urinary tract infection because this causes urinary frequency, urgency, as well as have some hematuria and could even be white cells. But for her, of course, we know that she had stones. Her right kidney showed no stones, and you may think, well, does she not have cystinuria in her right kidney? Yes, she does, but we see this quite frequently, not just in people with cystinuria, but all patients. For some reason, there's more sidedness. Some of them only make it on one side, which is actually the case for her, and there must be some other microarchitectural issues that result in stone formation on one side or the other. But in her left kidney, at the time that she had this acute event, she also had 3 other stones, and that's important to keep in mind for later. So what I didn't tell you in the initial 24-hour urine, that her total cystine was close to 1,900 milligrams per day. Normal is less than 100. And the concentration is important because the solubility of cystine is 250 milligrams per liter. And you can see that she's way above that, which is, of course, why she kept forming stones. So as far as the treatment, we want to get the concentration of cystine below 250. We are not able to change the amount of cystine that's coming out. Okay, so we have to do some other things. So one is we want to increase the urine volume, of course, to decrease the concentration of cystine. But in someone that's making this much cystine, excreting this much a day, she'd have to have 7 liters of urine output per day, which again is impossible for anybody to keep up for any period of time, maybe not even one day. And so what we do is we have medication that's called tiopronin. You may have heard the brand name Thiola. And what this drug does is binds covalently to cystine, and it changes its solubility. So it's in the urine that things change. It's not changing the amount of cystine that's coming out. For this medication, most patients typically need 900 milligrams or more per day, and they need to be dosed 3 times a day. Fortunately, there is an extended release generic formulation, so you don't have to buy they don't have to buy the brand name. But it has to be taken several times per day because it has to be in the urine when the cystine gets there, otherwise it's not going to be effective. And again, we continue alkalization to aim for the pH above 7.0. So 6 months later, I got a call after I had put her on tiopronin, and she had left renal colic, and she said she stopped the medication because it clearly did not work. And then the question is she correct? And that's why you want to think back to that earlier imaging study that I talked to you about. And this isn't her, but this is a similar situation. patient seen in an emergency room, everybody's focused on this left ureteral stone, which is causing all the action. But you can see this without any training in radiology that this person has a very large residual stone. And at some point, this stone is going to move, and that stone will get into the ureter and cause symptoms. We don't know what causes stones to move. We know how to keep stones from growing. We know how to keep stones from forming, but we don't know how to keep them from moving. But it's really important when you see a patient to make sure that you review the radiology reports or sometimes even the images themselves and tell the patient that they do have residual stones. They're not going to be very happy when you tell them that, but it's really important that they know so that they, for example, like what this woman did, is we don't want them to stop their medication. If they're doing everything perfectly, which she was, it will keep new stones from forming, but it, again, won't keep the existing stones from going away. Okay, cystinuria, again, another situation where we can completely stop new stone formation as long as they tolerate the medication. Okay, the third case here, Miss JB, 35-year-old female nurse with recurrent stones. Very commonly, you're going to see people in the medical profession forming stones, and you might start to think, why? Well, one of the things many of us learned in our training, the best way not to go to the bathroom was not to drink. And so it's very common to see lower urine volumes in individuals in the medical profession. Before she came to me, she had been first presented 5 years before with colic, renal colic, again, some of the worst pain that an individual can have, and bilateral renal stones. I want to mention this term right here, bilateral. So of course that means both sides, but we have no idea how many or how big the stones are. And unfortunately, the radiologists often say, oh, bilateral renal stones, completely unhelpful to us that are trying to prevent new stones from forming. So hopefully you'll have a good relationship with your GU radiologist and say, can you please not say bilateral? Can you please tell me how many on both sides and how big they are? Because when I do a follow-up, I want to know whether there's been any change or not in the stone burden. So this 35-year-old woman was otherwise healthy. So most likely stone type, excuse me. Again, you should always guess calcium oxalate if you want to play the odds. There's really nothing else in the history that can help us figure out what other types of stones she might have. But if you look at the urine sediment, once again, you would see these beautiful examples. These are calcium oxalate dihydrate crystals. If you look under the microscope, this is probably the best example. They're bipyramidal, very easy to see. This is a calcium oxalate monohydrate. Whether it's the dihydrate or monohydrate, it doesn't matter for our evaluation or treatment. It matters for the urologist, but not for us. So her stone was 95% calcium oxalate, 5% calcium phosphate. It's very common to see these mixed stones. Sometimes you'll see calcium oxalate and uric acid, but what you won't see are calcium phosphate and uric acid because of the pH difference. Remember, uric acid only forms in an acidic urine, calcium phosphate forms in a more alkaline urine. But this 5%, remember that these stones don't form just rolling around in the kidney. The vast majority of calcium oxalate stones grow at the tip of the papilla. There's something called Randall's plaque, which is actually calcium phosphate that's been deposited, and there's a whole story about how that gets there. But it's very common to see these combination stones because calcium oxalate grows on top of calcium phosphate, which is at the tip of the papilla, the Randall's plaque. So the CT report, I had already mentioned this to you about the quantifying number and size. And at the acute event, she had a 3 millimeter stone at her left UVJ. So as far as acute management for somebody with kidney stones, and you may say, well, why, Gary, why are you telling us about this? That's a urologic issue. Well, actually, it's going to be a nephrologic issue because when a patient has an acute event, after they've already seen you, they're going to call you first. And you say, why are they going to do that, Gary? And I'll say, because you answer the phone. Okay? You definitely want to have a good relationship with the urologist. Hopefully the patient has already seen a urologist in the past so that you can refer them right back, because in the acute setting, that really should be managed by the urologist. But if you don't have that luxury or they haven't seen a urologist before, you can start to think about, how am I going to manage this person with acute renal colic? Well, typically we just do watchful waiting, and then the question is for how long? And it depends, like many things in nephrology. So it depends on the pain. Can the pain be controlled with oral medication? Is there any evidence of infection? Because if there is any evidence of infection, that can be a medical emergency. Remember, if there's a stone obstructing the ureter, and if there's an infection proximal to that stone, the patient can get rapidly septic. There's pus under pressure, and they need urgent decompression. If you just see hydronephrosis, that's not a reason to do anything. If there's an obstructing stone over time, hydronephrosis will develop. However, if this episode could have been going on for 6 weeks or more, and I would even say 4 weeks, then you do want to do something urgently, or have the urologist do something urgently to decompress it, because the longer that there's obstruction, that can actually cause long-term irreversible kidney damage. We often see the creatinine increase acutely in these settings when there's an obstruction, but if it can be released or bypassed with a stent or other things in a relatively short period of time, there will not be long-term damage. As far as medications, alpha blockers have been shown in randomized trials to help shorten the duration of stone passage for stones that are 6 millimeters or larger, but they don't cause acutely for the stones to pass. Those big studies, the average time to pass was over 20 days, and it shortened it by 3 days. Certainly that's better than nothing, but there's been this misconception that you give an alpha blocker and it helps the stone just pop out. If there's reasons that pain can't be controlled, or you're worried about infection, or there's been long-standing hydronephrosis, then most urologists will go in and do a cystoscopy and ureteroscopy to remove the stone. There is extracorporeal shockwave lithotripsy, and when this first came out, we were very happy because it was much less invasive, but it's being used less and less at the major urologic centers because it just isn't nearly as effective as ureteroscopy. So this person had calcium oxalate stones, and so as far as the risk factors for calcium oxalate stones, I want to remind you, higher urine calcium, higher urine oxalate will increase the risk. The factors that will decrease the risk are higher urine citrate, again, a natural inhibitor, and higher volume, which will decrease the concentration of the lithogenic factors. I want to briefly talk about hypercalciuria. You haven't heard me mention that term before, and most other people, you would have heard it much earlier in the talk, but I really don't like that term or any of these other dichotomous terms, mainly because there's two reasons. One is the definitions are made up, and we'll talk about that in a second, and the other is that the risk is continuous. So it's not like there's some magic threshold. If I can just get the urine calcium or the urine oxalate below some level, that everything's going to be fine. So I put the word definitions in quotes because I don't want you to remember anything, but I do want you to be thinking about how do we define, quote, normal, not just in urine stones, but also in many of the other things that we do in clinical medicine. But the classic definitions of hypercalciuria, or high urine calcium, was more than 300 in men and more than 250 in women. And first question is, well, why are men allowed to have more calcium in their urine than women? Well, if men had higher urine volumes, then okay, maybe you'd say the concentrations are low, but it turns out men have, on average, slightly lower urine volume. So this is made up without justification. Please don't use a weight-based definition in adults, because that means if I gain some weight, that then my urine calcium should be allowed to go up. Doesn't make sense for stone formation. Hyperoxaluria definition made up. Hyperuricalciuria definitions made up. So I want to show you quickly just some data from one of our large studies where we collected 24-hour urine samples from both people who had a history of kidney stones, over 2,000 people, and over 1,000 controls. And you can see here in these three large cohorts involving very large numbers of people, but more than 3,000 24-hour urines, you'll see that with increasing urine calcium down here, adjusted or independent of all the other urinary factors, the risk goes up. There's this little inflection here, and that's just because we cut it off here. If we had extended this, it's pretty linear. So there is no magic threshold. So if we had said the classic definition for a woman is less than 250, but you can see these in this female cohort, for example, here, the risk is already close to 3 times higher than if the urine calcium is less than 1. So again, in the men, it's the same idea that this is in the yellow is the men, that the risk of, quote, within the normal range is already way higher. So please don't use these dichotomous cut points. I want to give you some example of some national labs that have different reference ranges. Again, most of these definitions are made up. They're required by the College of American Pathologists or something to have reference ranges, but these are continuous values. Okay, the other thing I want to point out is that certain labs will calculate the supersaturation. This is a calculated value, but it means the likelihood of crystal formation. And it takes into account the volume, the calcium, the oxalate, citrate, all these things that we are not able to just in our head come up with an integrated result. So the supersaturation we want to get to as low as possible. You can see this reference interval here says less than 7.5. The scale here is half of what that other lab uses, but this is from Megan Prohaska, who looked at supersaturation and likelihood of crystal formation or stone formation, and you can see again it's linear. None of this is rocket science, and we know that blood pressure. If I'm 131 over 81, everything's terrible, and if I'm 129 over 79, everything's fine. We know that's not true. We know the risk of stroke, heart failure increases linearly. Same thing with A1Cs. It's not like there's some magic threshold. So again, for stone disease, anything we can do to get people down the supersaturation curve. So in this case, this person with low urine volume, we want to get her urine volume up. Yes, I'd like it to be 2.5 liters per day, but if we can get it to 2 liters per day when she was at 0.8 liters per day, that would be a huge benefit to her. I want to get her urine calcium down. Would I like to get it less than 200? Absolutely. If I can get it from 380 down to 250, that's great. Did I win completely? No, but that's a huge help. So there's lots of other things that we can do to reduce the supersaturation. So people often say, well, how much should I drink? We say, as I've been telling you, that low urine volume is a risk factor. So we want to know how much to tell people to drink. Well, we all know from even the ICU how limited our ability is to determine what the insensible losses are. So people can't just drink 2 liters and expect they're going to make 2 liters of urine. They're going to be insensible loss from sweat, from breathing. That first patient I told you about had chronic diarrhea. There's all sorts of things. So I don't tell people how much total to drink. I tell them how much more to drink. So in this case here, the urine volume is 0.8. Ideally, I'd like it to be at least 2 liters or 2.5 liters. So I tell this person that they have to drink at least 1 and preferably 1.5 liters more per day. This value here already is taken into account all the insensible losses. So any of the additional fluid that they take should be absorbed and then come out as urine. And also I want to remind you, please don't prescribe beverages that have calories in them. So if the total volume doesn't increase, what does that mean? Well, it means that the person isn't drinking as much as you'd like them to. Please believe me, nobody wants to get a second kidney stone, okay? And if they are doing the best they can and drinking as much as they can, then that's as much as they can drink. You may try to help them find some strategies, but there's some people who it's just very hard for. So in this case, if the urine calcium even isn't that high, but the urine calcium concentration is high, then I will use a thiazide diuretic. You may say, Gary, in the New England Journal a couple of years ago, there was this big study that said thiazide diuretics don't work. That is not true. That study used clinical events as an outcome, and more than half the people had existing stones. So we already knew in advance of that thiazides don't reduce the risk of passing existing stones. Buried in supplemental table 12 is this study where they only looked at radiologic stone recurrence. So we knew that actually these were new stones that were forming. And you can see here that there was a 50% reduction for hydrochlorothiazide. So this study, despite what the authors concluded, in my mind, was the best evidence that we've had to date how effective thiazides are. And also in this case, they used the shorter-acting hydrochlorothiazide, which clearly was effective, though we still think that a longer-acting one like chlorthalidone may be even more effective. So as far as follow-up, repeat 24-hour urines. I usually do that after 4 to 6 weeks following implementation of new recommendations. If that doesn't work, then you need to adjust the recommendations again and repeat the 24-hour urine. And sometimes you have to go in the cycle a little bit, but eventually you'll be able to improve the composition of the urine to dramatically reduce the risk of new stone formation. So how do you know whether it's being effective or not just besides the numbers? Well, follow-up imaging, you want to look for new stone growth or new stone formation. I do use ultrasound. I had told you before about CT. If a patient has multiple existing stones, ultrasound usually isn't going to be good enough to distinguish whether there's been stone growth. And so you may need to use CT. If your institution will allow it, please use low-dose non-contrast kidney-limited CT. So, again, only get that slice and hopefully reduce the radiation exposure. So In the short time I have, I'm going to just give you a few more things. Always measure 2 24-hour urines at baseline because of the variability. Find out the stone composition by analysis if you can. Make sure you repeat the 24-hour urine in a reasonable time after recommendations have been implemented. It's very hard for patients to reduce sodium intake. That's the only way thiazides are going to be effective if they can get their sodium intake down. They may end up needing to see a nutritionist. And again, helical CT is the most reliable imaging study, but remember, it does have radiation. I included a bunch of other slides here. This is with some examples, but that's strictly for you to work out on your own. Thank you.
Thank you, Gary. That was absolutely a fantastic, rapid presentation of the treatment of stones. I appreciate it and learned an enormous amount. As with Dr. Opel's questions, we're going to save Dr. Curhan's questions until the end of this session so I can introduce the next speaker.